wherever you want to go.
Fantastic.
It is all in there. This man right here can talk forever. We can listen forever with the amazing stuff he has to share. So here we go. All right, it is Thursday night and we are live on Facebook and also on Zoom with one of my favorite airway people in the world. And here is Dr. Jeff Rouse. Thank you so much for accepting our invitation and being here with us tonight.
Thanks, Renata. I appreciate it.
Of course. Angela, would you like to do the honors? I think she's frozen or she always mutes herself and can't unmute. So I will start.
Oh, can you hear me?
Yes, I got it.
Okay.
All right. So the topic tonight is Airway Prosthodontics, dental diagnosis and treatment planning. Our speaker is Dr. Jeffrey Rouse. He maintains a private practice in San Antonio, Texas, and practices with Dr. Greg Kinzer and Frank Spear in Seattle, Washington. In 2017, he became a member of the resident faculty at Spear Education in Scottsdale, Arizona. He was also an adjunct assistant professor in the Department of Prosthodontics in the University of Texas Health Science Center in San Antonio from 2004 to 2019. After graduation from dental school in San Antonio, Dr. Rouse completed a 2-year general practice residency at the University of Connecticut Health Science Center. He practiced family dentistry for 12 years before returning to school. Dr. Rouse received his specialty certificate in prosthodontics from the University of Texas Health Science Center in San Antonio in 2004. He's a member of the American Academy of Restorative Dentistry, the American College of Prosthodontics, and past president of the Southwest Academy of Restorative Dentistry. He has written numerous journal articles, including a portion of the annual review of selected dental literature, published each summer in the Journal of Prosthetic Dentistry. He has a textbook published in 2016 by Quintessence, how do you say that, is that right?
Yep.
Titled Global Diagnosis, is that right? A new vision of dental diagnosis and treatment planning, written with his teacher partner, Dr. Bill Robbins. Furthermore, he has contributed chapters on porcelain veneers and interior ceramic crowns to 3 editions of a dental textbook. Dr. Rouse lectures nationally and internationally on a wide variety of topics ranging from dental aesthetics to airway prosthodontics. So let's start. And I know there's much more that we couldn't add there, but let's start with our first question, which is, what is airway prosthodontics?
That's a good question. Actually, one of the little icons of people that are in the meeting just popped up, and Kathy Starnes, the myofunctional therapist in my office and my hygienist for years, is here. So, which is kind of bad because I can't lie. She'll call me on it. So, anyway, so airway prosthodontics is. Let me back up. I started a research project in my office in 2007 on bruxism, actually about 2004. In 2007 and 8, I figured out that in the literature, they were starting to show a relationship between bruxing and airway issues. And so we started building from there into the sleep world. At the very beginning, it was about, in order to deal with my bruxing patients, I have to make sleep appliances because that's all we knew to do, mandibular advancement appliances. That was it. And so I would work with physicians and I would work with medical insurance, and I hated every minute of it. You mess people's bites up and the appliances are nasty, and there's just nothing. I mean, I guess in a way, if you make a person healthy, that's fine, but the rest of it is lousy. So I hated every minute of that. And I wanted to figure out, what we can do, because I kept running into the people that y'all probably work with mostly, which are young, fit females and kids. Young, fit females can be guys, but they're thinner. They're not the obese patient. They're the ones that have muscle pain, headaches, neck pain, fibromyalgia, and then the kids that just aren't growing and developing normally. And sleep appliances, mandibular advancement appliances, didn't have any, it wasn't an answer for them. And so I had to find something different. And what I recognized was that just what we do in dentistry can have a huge impact on those people's lives. I mean, just traditional orthodontics, or now some of the newer contemporary orthodontic techniques, can absolutely change lives. Even if we don't get anyone else involved, we can make it better. If we get, say, an ENT involved, it better still. And so I had an ENT in my office for 5 years. And then I started learning about myofunctional therapy and began, Myra Kirkland was in the office for a little while. And then Kathy got an interest in it while she was my hygienist. And so she did hygiene. And then after finishing the day or on the weekends or on Fridays when I don't work, she would do myofunctional. And now she's doing myofunctional in the office full time. So we just evolved. Well, you can't call that sleep dentistry. If you do, you're doing sleep dentistry where you're actually doing sleep dentistry a favor, because sleep dentistry is such a narrow-minded, poor solution to a problem that requires complex solutions of altering the anatomy and then correcting the anatomy, making it ideal again. And so it isn't mechanical, it's biologic. So I had to give it a different name.
I love it.
And I called it sleep prosthodontics for a while, but then it hit me that it's not sleep, it's 24/7. It's how you breathe.
It is breathing.
And so we changed it to Airway and Airway Prosthodontics. By that, prosthodontics is the study of the stomatognathic system. So Airway Prosthodontics is a study of what a poor airway, how a poor airway impacts the entire stomatognathic system. And honestly, I forget that that's what we call it. Somebody reminded me not too long, oh, you do a workshop in that. And I went, oh yeah, I do. It has become just dentistry to me. That's the way I look at dentistry.
Exactly.
Patient came in today and they wanted an appliance to stop bruxing. And at the end of the appointment, I said, in order to stop bruxing, you need ortho. You need your tongue tie. Actually, that's why it was interesting that Kathy's here, because I actually got her and brought her into the room because I had a question about the tongue tie, and I asked her a bunch of questions today. And
I don't have anything on my teeth. Am I good? I'm smiling over here, but I was just eating to make sure.
So that's Airway Prosthodontics. Airway Prosthodontics it's not sleep, it's airway. And prosthodontics is anything affecting the stomatognathic system, which is what this really does. We look at what does bad breathing, stressful breathing, how does that impact the things that as dentist I see every day. Someday I hope it's just called dentistry. Honestly.
Right? I mean, should we be doing dentistry any differently than this? There are so many patients getting missed out there.
Dr. Rouse, can I go ahead and quote you on that? I'm going to be speaking to a large group of dentists on Monday. Can I quote you on that?
Sure.
On what airway prosthodontics is? Sleep dentistry is now called. And this is from Dr. Jeff Rouse.
Yeah, I guess I'll have to throw in the caveat that a lot of people still do sleep dentistry, right? They still just make appliances. And it's not that it's the wrong thing to do. It's just they're making appliances on everyone. They have one tool.
Yes.
And if you go through the literature you do something simple like nasal steroids before you go to sleep. Well, that cuts apnea by a huge amount. If you look at all the literature on myofunctional, that cuts apnea by a huge amount. If you look at nasal dilators, like a mute dilator or a breathe right strip, that cuts apnea by a huge amount. If you, there's so many little things you can do that honest to God, so you can quote me on this. There's no reason that a mild to moderate apnea patient should ever end up in a mandibular advancement appliance. They just shouldn't. And if they do, there's something neurologically damaged in that person, so severely neurologically damaged that we can't get to it and heal it. But there's absolutely, it's just laziness that we make those appliances for that type of patient. And even, to be honest, even on severe patients, I don't think we need to go there. I didn't make a single one last year. I made 0. I made 4 the year before and 4 the year before that. So I'm going to have to read the manual to remember how to put the sleep appliance in and adjust it the next one I make, because it's been so long since I've had to do it.
So since we are in the subject, is there a time where only a mandibular advancement appliance will be the only option for a patient?
The only option? No,
Mhm.
never.
Okay, perfect.
There'll never be a time, but the patient may put restrictions on you
Yes.
that make it the only answer for them. If they say, I won't do ortho, I won't do orthodontic, I won't do whatever, I won't release my tongue, I won't do myofunctional, I won't use steroids, I won't do this, I won't do that. Yeah, absolutely. But that's so there. So, well, let me just walk through why I didn't. I said I didn't make a mandibular advancement appliance, and I didn't. In the traditional sense of a sleep appliance last year. I made appliances all year long, though. I just made the right appliance. So, have y'all ever met anyone that said, I can't sleep without my night guard? In fact, the majority of the people on this call will say that, I guarantee it.
Yes.
Like all young fit females go, oh my God, I love my night guard more than my husband, right? They do, you do. In fact, if you had to give up one, it's like that. I don't know. I'm thinking, give me a minute. So why does a night guard make you feel better? Made you sleep better. It didn't get rid of some tooth interference that drove you crazy all night long. That's not the reason you liked it. The reason you liked it is it made your airway better all night long. You were able to breathe. So that added vertical dimension allowed your tongue to leave the back of your throat, go into your mouth, and created the room required to be able to sleep well. That's why a night guard works. So people with airway issues, there's a ton of studies done with night guards that say that 50% of the patients that wear night guards make their airway worse and 50% make it better. That's why some people you make night guards on in dentistry and they don't wear it at all. They put it on, it's on the nightstand in the middle of the night. But the others love it so much they couldn't possibly think about going to sleep without it. So if you came to my practice and you had low levels of apnea that a night guard would fix, and I was just doing sleep dentistry, what would I make you? I'd make you a mandibular advancement appliance that moved your jaw out 6, 7, 8 millimeters. Would it fix you? Yeah, your airway would get better. But what else would it do? Well, you'd hate wearing it. It would hurt your jaw. It would be this big and bulky thing that would probably interfere with your sleep in some way. You probably would give it back to me at the end of a year. There's a 50-50 shot that that's going to happen. And for sure, your bite's going to change because 100% of the time that happens. A little or a lot, the bite always changes. So I make appliances. I just make the right appliance. And so we created a thing called the Seattle Protocol, which is a temporary way of walking through different appliances to find the right appliance for people, rather than just making a mandibular advancement appliance. So your question was, does everyone have to have a mandibular advancement appliance? Are there some people? No, they might put a limit on me, in which case I have to walk them through the protocol. And there are a few people, I told you I made 4 the year before this and 4 the year before that. There are a few people that walked all the way through the protocol, got to the very end, and that's what we had to make them. And I hated every minute of it, but at least I knew that was the only thing that was going to work for them.
Exactly.
So I had to make it at
Mhm.
that point in time. So yeah, so there's some people that's going to happen to.
Amanda is asking, do you find those are your tongue-tied clients more often than not?
You know, I wish I could say that I track that. I don't. I don't track it. Yeah, let me just as an aside on tongue ties. I think that myofunctional therapists, and what I begin my section in the lecture out at Spear with on myofunctional therapy is when I put a big thing, we're going to talk about myofunctional therapy, is y'all are starting to get known as the tongue tie people, and you shouldn't be known as that. I say when I begin that section that myofunctional therapy is not about tongue ties. Myofunctional therapy is about close your mouth, put the tongue in the roof of the mouth, breathe through your nose, swallow correctly. Now, there are other things you can do, but those for me are the four main things I want you to teach my patients to do.
Thank you. Thank you. Yes. I have patients that call me all the time asking me, so how many sessions do I need before a tongue tie release? I don't give a number. That's not how I work. I don't even know if you're going to need one by the end, by the time we're done with therapy. I usually see patients 14, 15, 16 weeks before I even send them at that point, if they really would benefit from release, if whatever we worked on therapy, it's, if there's still limitations. But yes, I love that you said that. Thank you. All the myofunctional therapists here are saying thank you.
Yeah. Well, it really, so to me, the goals are those four, and then you can put other ones on there. But those four goals, a thing that may limit your ability to meet your goals is a tongue tie, right? So it's not that you are a tongue tie specialist, it's you're specialist in all this other stuff. And you know that one thing in your way is a tongue tie. Now, by the way, y'all need to expand into learning how to read arch forms better and occlusions better and jaws better, because a huge part of your restriction is the oral cavity is too small.
Yes.
And the teeth are in the wrong place and the skeleton's in the wrong place. And so you're focused on tongue tie and you're missing the big picture, which is the skeleton's all messed up. And you look and go, well, they're not tongue tied. I don't know what I'm going to do. Well, you have to work in concert with an orthodontist or a restorative dentist that knows how to deal with that and make the anatomy ideal. The anatomy goes well beyond tongue ties. And I've seen a lot of myofunctional therapists that do great jobs at doing what they do, but they miss the picture, which they show me cases. And this is not Kathy, but a person I worked with before, and she was showing me a case where she closed an open bite through myofunctional therapy. And it was like, that's awesome that you did that, but this kid needs expansion. Everything is too small. So you just spend an entire, X number of times trying to get the tongue shoved back into an oral cavity that's way too small.
Yes.
So anyway, just you mentioned tongue tie, and I do my best to try to highlight to dentists that y'all are not, that's not your purpose in life to deal with tongue ties. It is a piece of why you can't effectively achieve your goals, and you have to get it corrected.
Yes.
So
that is absolutely right. More myofunctional therapists need to listen to this. And I feel like a little bit of that comes with experience and working and taking more courses. Only taking one course is not enough for you to start seeing all of this that we're talking about in patients. But the tongue space talk has been very prominent in the recent months with our social accounts that I've noticed. Everybody's been talking a little bit more about tongue space, how important that is. I don't know, we haven't mentioned yet. Well, we did talk about how differently you look at your patients now, and what are the 5 diagnostic pillars that Spear came up with?
How do I look at my patients differently? You know,
Before-
well, probably the easiest way to say that is to tell you about a lecture that I did with a friend of mine, Jim McKee. He's a dentist up in Chicago that works on, is a joint, deals with joints and pain. And we just spoke at the American Equilibration Society in Chicago. And I took the maxilla and he took the mandible. And so the maxilla to me is where aesthetics and health lie, and the mandible is where function lies. So health and beauty are the maxilla, and then how you speak and function lie in the mandible. Everyone, one of the speakers before said that all the airway problems and sleep issues lie in the mandible, and I could not disagree more. The maxilla is where all the problems lie. And so the ability to breathe through your nose is the end goal, and the mandible really has very little to do with that. You can, yes, if you have a severely constricted mandible, but it's pretty rare. Interesting information out of nasal breathing studies say that if you're breathing through your nose, the airflow across the turbinates causes the tongue to react and get out of the airway. So even if your mandible is small and your tongue is going back into the airway, if you can get yourself to breathe through your nose, you're going to be able to affect change in that. Problem is, if your maxilla is too small, you can't breathe through your nose effectively. The vomer bone of the nose is an endochondral bone, meaning it has a set distance it's going to grow. Your septum, in other words, is going to grow to a set dimension, like the mandible. If the maxilla is constricted, then it will always deviate 100% of the time. And there are a number of studies out now that say that if you do expansion, that you actually will fix the deviation, especially if you do it in kids. But you can also do the exact same studies in adults now, and we're fixing the septum. We're improving it or fixing it dramatically.
Wow.
So the maxilla is where all of it lies, all health lies, all the benefit lies of dentistry, I think, and ortho and orthognathy. So I said that, how do I look at patients differently? The end of the session, there was a Q&A, and the last question in the Q&A was posed to two people that had focused on the mandible. It was a very long, complex question about how would you deal with a patient? And they described the patient, and they described the pain in the patient. They described the movement in the patient. They described the jaw relationship in the patient. They described everything about the patient. And they said, would you begin, Dr. McKee, by telling us how you would deal with this patient? And I stopped him and said, wait a second. Your question is the problem. You just spent you spent 2 or 3 minutes describing a patient and never once mentioned the maxilla. You didn't tell me anything about where the teeth are, where the skeleton is, how the nose is, how they can breathe through the nose, what the back of the throat looks like, what the soft palate looks like. You didn't tell me anything about the maxilla. And so if you talk to these other gentlemen and get their treatment strategies on the mandible and the maxilla is deficient, the patient is still unhealthy. The patient still can't breathe. The patient will still be in pain. The patient will still be ugly. So
It's true.
you ask me, how do we change? How does it change? It changes because we focus on the maxilla first.
Mm-hmm.
And we never accept a deficient maxilla. And we get it set exactly right, the way we want it, like we would a denture. In dentures, when we learn in dentistry, in dental school, how to make a denture, we always learn to correct the wax rim first before we ever set teeth. But what we do in dentistry is we accept the wax rim the way it is, and we try to work the teeth within the wax rim. And so we take teeth out for bicuspid extractions. We slenderize teeth. So interproximal reduction to get teeth in. We lean teeth, we angulate teeth, we reshape teeth, we do all kinds of junk to get people in, teeth in a constricted maxilla. The problem is that all we're thinking about is aesthetics and function. We're not thinking about biology or health. So for me, like the patient that came in today she said, I want a night guard because I'm bruxing. And I'm like, no, you need expansion, and you're 47. So you need more than just a regular expander. You need a surgical based expander. And then you need your mandible surgically altered in order to get it to the right location. And all these problems will be gone because when you take the splint out in the morning, you go back to all this. You're not healthier.
Bending.
So pillars at Spear, I guess what you're referring to is facially generated treatment planning, which is aesthetics, function, structure, and biology, which is exactly that. Frank Spear years ago said you always begin rehabilitations by setting up the upper teeth first. Then you do the lower teeth. Then you figure out if the structure is okay. And finally, if there's any disease, you take care of it. What changed at Spear when I was added on was we actually begin with the skeleton first. We call it airway, but in fact, it really is the craniofacial relationship. Is the skeleton normal? If the skeleton isn't normal, then we fix that. We say, we're not going to cram teeth within a confined skeleton, even in an adult. We're going to get the skeleton where it's supposed to be. At least we're going to offer you an opportunity to get the skeleton where it's supposed to be. And then we'll set the teeth up because the teeth will be in a more beautiful location. They'll be functional, be more functional than they would ordinarily. And most importantly, you'll be healthy. So that's what's changed at Spear. And that's how I look at my patients differently. I was always about the mandible as well. So I criticized the question, but it was really me. That was me forever.
We have a couple comments on the chat. Dr. Hernandez says, thank you so much. Love your views on airway dentistry. So humble and respect for the body. What is your approach to work with individuals with UARS? I have heard so many different opinions and would love to hear your views and experience.
Yeah. So UARS is the majority of the patients that I see. Most dentists call that patient a TMD patient. So a myofascial pain, TMD, headache patient, whatever they may call it. They might also call it a bruxer clincher or an occlusal interference type of patient. But we have a lot of names for them, but they all end up being the same UARS patient. TMD patients in my practice are typically younger women. Basically what I tell dentists to do is think through who you've made a night guard for in the last year. And that's your UARS patient. And when you also look at people that clench or grind in your practice or complain about cracking a tooth or cracking something, then that's your UARS patient as well. Old fat men don't do that much damage. They have erosion, they wear teeth down, they have apnea, but they don't. The UARS patients are the pain patients. So there's a guy named Barry Krakow that was a Stanford sleep physician. He is alive. He moved from Albuquerque to Florida recently. But he did a significant amount of research on insomnia patients, another term that's equivalent to UARS. The UARS patients are the ones that wake up at 3:10 in the morning every morning, right? They're fatigued. And Krakow found that the UARS patients are responding to not apnea, not hypopnea, but more minor airway events, hence the name UARS. But he also found that 90% of them, if their sleep aid isn't working anymore, that's what the problem is. It's respiratory. And 100% of them, essentially 100% of them that wake up in the middle of the night and can't return to sleep effectively, that's what they are. That's who they are. They're UARS patients. He then said that those patients will blame, I've got so much on my mind, in other words, mental or physical. I've got X pain, my back hurts, whatever. They'll come up with a body reason. So I'm stressed. Actually, the lady today that came in that Kathy saw, the complaint was, I end up doing this when I'm stressed. I'm like, no, you end up doing this when you have respiratory events. And so they just blame it on that. The interesting thing about Krakow's research, though, was that he said that all you need to do with a UARS patient is actually get their airway under control. And he was honest enough as a sleep physician to say that it doesn't matter how you get it under control. You can get it under control by putting them on CPAP, which is sleep physician's way of doing it, which, by the way, is not a tool, honestly, for UARS patients. One study was done where the compliance rate at 3 months was 2%. So it ain't going to happen. He then said you could use a mandibular advancement appliance. Once again, you don't need that big of a tool, but that's the only one that he knew of research associated with it, because that's what we do, right, in sleep dentistry. He said that you could do nasal surgery. And then he also said you could use things like nasal dilators. You could, he listed a bunch of different things that are options. What I took from that is Krakow is telling us the insomnia, UARS, TMD patient, however you want to describe it, just needs their airway resolved. The difficulty with UARS patients is that it's not big events. Big events are easy to fix. Little events are hard to fix. And little events are hard to fix because people are so reflexive in everything. Everything bothers these people. So you have to get everything perfect. The respiratory part of it, but also the environment has to be perfect. I mean, we had a girl in the office that I know we had that was fixed. I mean, I know that everything was fine, but she had a dog in her bed. It was like, you got to get the dog out of the bed. I mean, it's crazy.
We had somebody recently with 11 cats.
Yeah.
I said, do you really want to get better?
I love when they tell me, oh, my dog doesn't move around. And I'm like, no, you're crazy. Your dog absolutely moves around. I dated a girl who she had 2 dogs. I called one micro and the other arousal because it was crazy.
I love that. We have so many questions coming in, and I know Angela's ready to ask her question. But since we're talking about expansion, I wanted to ask your opinion. Do you have a preference or transverse versus AP? One more important than the other? What do you do first? Both.
Yeah.
Which one is the bigger issue?
So no one knows.
Okay.
We'll just go with no one knows right now. I'm going to suggest that transverse is more important. And the reason is that the data on transverse expansion shows that the septum gets better. So that's really important because our goal, my goal, your goal is you got to get people to breathe through their nose. Yes. And so transverse creates a better environment from a nasal breathing standpoint. So that's important. Transverse is easier to do. So that's good. So we can get it easier, right? It's not as complex of a move. It also creates more room in the mouth. So oral pharyngeal airway is better. But probably if you want to go to science, the best science that I've seen is that they looked at the oral pharynx and found that the AP change associated with appliances was not the key to making the airway better. It was the lateral expansion that they got. That was the key to it. So lateral is more important apparently than AP. But I would love to get both if you could. But the other thing to remember, another just thought, because it hit me the other day when I was reading something, is if you get a patient to do orthodontic surgery and they do it as a one-piece maxilla, they don't get any transverse expansion with that. They just move forward.
Wow.
So unless they do a three-piece and they actually make, or a two-piece and move the segments, then you're just taking a small maxilla and moving it forward. So you got to get them to widen it. So it just,
Wow.
like I was reading an article and went, God, that's so obvious, but I never really had thought it through.
Do you guys understand why I was so excited about today? Why? When Dr. Rouse said yes, I actually called Beth. She was the first one that I called. Beth Sohayo, she's a myofunctional therapist in Atlanta and Alabama now. She said, "Hi, Dr. Rouse. Your teachings are the core value of my myo practice. We actually met in your class at the Hinman.
Oh, is that right?
So I went to
Yeah.
the Hinman and there were,
Oh, I
usually,
remember. Yeah, y'all were sitting in the
yes.
front row. Yeah.
Usually you take
Yeah.
one, you take a course in whitening, you do
Y'all
one
tracked
here,
me
one
around.
there. I took every single course that you offered that year. I just sat in your room the whole time. But my Lord, I mean, to this day, just like Beth said, the core value, the way that you teach is just fantastic. Like, yes,
Thanks.
Angela,
That's
go
nice of
away.
you.
Okay. Dr. Rouse, we have so many questions here for you. And I think you're touching on a lot of the questions that we have, but I think we're just going to go ahead and start throwing these questions at you. Since you were talking about a younger age and these kids and working transverse, what are the different categories of airway patients and how can we best capture them during screening at a young age?
I don't know. I guess I don't understand the. So we're talking about kids and categories.
I think the categories that they say, the young fit female, the old fat man, and
yeah. So as far as how my mind works, my mind puts them in three categories. Children is one category in and of itself. Young fit females. And remember, my mind, it's just the way my mind puts people in boxes when I'm listening and looking at, like when I look at a medical history, when I'm listening to their complaints, when I'm looking in their mouth and seeing, my mind puts them in places just so that I can standardize my thoughts about them and I can help them through the process. So young fit females are typically young fit female. So they're fit, meaning they're not obese. Obese would be apnea. Young female means that they have progesterone. So progesterone is a pharyngeal dilator. It also creates a drive to breathe. Well, a man can be a young fit female, but the way they overcome the lack of progesterone is tone. They're fit. So they have muscle tone. And that's what keeps their airway open. And so their body's reflexive and reactive to airway events, but it's because of the tone. So the last group is old fat men, and old is lack of tone and fat is obesity. Men tend to put on fat in their necks more than women do. So tends to have a higher percentage of men. Men also tend to, we have more testosterone. So if there's a tongue tie, they tend to grow those big fat tongues as well that block off airflow. So lots of reasons that men are more prone to having apnea. And so that's that group. But honestly, the worst apnea numerically that I've ever seen was a woman, a younger woman. So, and fit, like she ran marathon. It was like the weirdest thing ever. So just because you're a guy doesn't mean you're in the old fat man category. And just because you're old doesn't mean you're there. I have a 64-year-old guy that's a young fit female. So it's just how my mind puts them in boxes. So that's the categories.
awesome.
The other one was on screening kids.
How we can best capture them during screening at a young age.
Yeah. So it depends. If you're a hygienist, then you have every advantage that I have in finding them. There's nothing I do that's any different than the stuff y'all do at your exam. You're looking at everything I look at. So you're looking at a health history, and if the health history has a history of reflux, if you start even earlier, You can
Mhm.
start with, did they breastfeed, and all that. You can start way back, and or you could even start even further back. You can start with, how did you do during your pregnancy, and did you have, just tell me about the pregnancy if you want to go that far back. Because that now, the new data is, if the mom has apnea during pregnancy, then a ton of the problems that the kids are going to have are related to that.
Wow.
So getting to the mom during pregnancy should, if I was a young dentist setting up a practice, that's where I would go. I would go get that group of people, because you can have huge impacts on the next generation if you can get to them. But if at whatever point you want to, C-section, was it C-section? How'd the kid do? I mean, you can, whatever your interest and your level of knowledge is, you can go back that far. But if you're simply just focusing on the kid, you look at medical history, and you look at attention deficit and erosion, and, and all the other, do they have any other health issues? So go through the health history with the kid and pick up things that you're going to find off health history types of things, and then start looking craniofacially at the kid. You're going to see all the same stuff. You're going to see either long vertical growth of the face, which is the typical adenoid facial type. You're going to see constricted arches. You're going to see wear on the teeth. You're going to see erosion on the teeth. But you'll also, I guess we can go into the idea of what I do during an exam. An exam for me is exactly the exam y'all do. Every new patient exam that you do, you're going to go through the dental part of it, but you're also going to do you're going to do a cancer screening on the patient. And the cancer screening on the patient, you have to look at the face. That's part of a cancer screening. And you're going to look in the mouth, and you're going to look for lesions, and you're going to look in the floor of the mouth, and you're going to palpate the floor of the mouth. And when I'm palpating the floor of the mouth, as I go to the other side of the mouth, I actually run across the frenulum to see if I feel a tie or sense a tie. And then you're going to look at the back of the throat for cancer, right? Well, it's the same thing there, except you just look at different things. You look for tonsils, how big they are, and Mallampati score, and whatever else you happen to look for. I personally look at palatal-pharyngeal width to see how wide the airway is, and I look at the AP distance. Although there's no grading of the AP distance, no one ever has set up a number, but you can tell if it's really close to the back of the throat or not once you look at a few people. And so that's what I look at. So honestly, when Kathy was working with me, we had all this stuff. She had already done it all by the time. In fact, that we'd meet in the hall, like by the afternoon when we met in the hall, I'd go, wait, let me guess, the patient's tongue tied, and like, yeah. So I mean, yeah, Kathy had it all done before I had even be there. So there's nothing magical about my exam that y'all don't already do.
Awesome. Dr. Rouse, Dr. Hernandez is asking, does a palatal torus impede expansion?
Oh, yes. Well,
Great question.
So does it impede expansion on a kid? I have no idea. But I honestly don't know that I've ever seen one on a kid.
My daughter's 7. She has a small torus forming already, and we just started expansion. So I'll let you guys know.
Yeah. Interestingly, there's a theory remember I talked to you about vomer, that the vomer that's the bone that's right above the palate and in the nose. And there's a theory that on deviations, if the maxilla is constricted, the vomer has to warp, right? But there's also a theory that one of the ways that it can also adjust is to go down into the mouth, so that the palatal tori is actually the vomer trying to find room.
Wow.
So,
I know when I saw that and I felt like it came out of nowhere.
Yeah. So I don't know. That's just I don't know. That's like something I learned at a campfire or something. I don't know. There's no science to it.
I wonder if somebody does come in with a really big torus, do they usually remove it before?
So if you, so let me back up to do it a different way, which is if you decide teenagers, 20-year-old, 30-year-old or whatever, we're going to do MARPI expansion. We're going to
Mhm.
do microimplant assisted expansion. The size of the tori may be too large to put the appliance against it and get it to pop open.
Mhm.
In which case they go in and take the tori out, let it heal, and then they put the MARPI on afterwards.
Wow.
So let's go. I guess the answer to the question is, in an adult, a large palatal tori would impede expansion. They would remove it, let it heal, and then they'd put the expander on.
Kimi is asking, she would love to know what Dr. Rouse thinks about non-surgical expansion options for adults. Are you seeing success, or is it really not achieved well for adults? Any favorite treatment methods or appliances for skeletal expansion, true skeletal expansion?
Yeah, so I love it. We use MSC, maxillary skeletal expander, that Juan Moon developed. Although one of the ortho groups is actually doing CAD design on theirs and creating custom appliances.
Amazing.
That's where it's headed, by the way.
Oh.
Where it's headed is, we're going to find the best place to anchor in the bone, and we're going to design where to anchor in the bone, and we'll use multiple TADs. They'll put the TADs in off of a surgical guide,
Mhm.
and then they'll custom design
The appliance.
the appliance to those TADs, because the MSE right now, the weakness is that you have 4 holes and you have to move it around and find the best bone you can, and then you put it there. Well, if they don't all engage in good bone, you don't get the same kind of tension created in the sutures to pop it open. Whereas if you put it in great bone everywhere and then design the expander to go to the great bone, then you're going to get better tension.
Wow.
So that's where it's headed, and it'll be here.
Any
Couple years.
I know that that's really considered non-surgical, but any expansion for adults without TADs? Any of the other?
No, the rest is tipping.
Thank you. Let's see, Jillian, any tips for screw retained hybrid denture patients that now have difficulty getting palatal suction due to the prosthesis covering incisive foramen? She's a hygienist in prosthodontist office. So screw retained hybrid denture patients cannot suction now.
Screw retain hybrid can't suction with what? Their tongue again?
Yes.
Is that what
They
she
have
means?
difficulty getting palatal suction due to the denture, the prosthesis covering the incisive foramen. I guess.
Yeah, I mean, I can give you, I don't have an answer for that. The answer, okay, so I'll give you 2 answers actually. The first answer is, you might ask the dentist in the practice, depending on the design. A lot of times the lingual aspect of that maxillary anterior is really thick, and the acrylic is thick, but it doesn't need to be thick, depending on the implant placement. And so there's a possibility they could remove it and thin it down quite a bit. That is possible. So have them look at that. The other is just an awareness for y'all that when teeth are removed, you lose a significant amount of buccal bone. And then when you place implants, you've got to put it into good bone, which means you're going to put it more lingual. And then when you create a prosthesis, you have to have at least 2 millimeters, at the very minimum, 2 millimeters of thickness to the lingual of where the implant is, at the very minimum. And so you now have constricted the maxilla significantly over what it was originally.
Wow.
So maxillary hybrid prostheses are really, really impinging on the oropharyngeal space. And so y'all are going to have a tough time with that one, because it's bad. It's really, really bad.
Dr. Hernandez is asking, so many of my young patients have had palatal expansion with orthodontics. then perfect alignment of teeth, yet they are deficient in their intermolar width and have airway issues. What can we do to avoid this? How far do you expand? Thank you for answering these questions. You need to go train a spear.
I don't, I agree with Dr. Hernandez's observation. The problem is that most of the time, so for everyone's kind of knowledge, orthodontists, when they expand, they don't want to go into what they call a Brody bite or a buccal cross bite. They don't want to take the upper teeth and move them so far out that they don't interdigitate with the lower teeth. The problem is the lower teeth are lingually inclined many times and are constricted. And so unless you take the lower teeth and fully expand the lower arch out, you don't know how far to push the upper teeth. And so I find that by the time we push the upper teeth out and go, that looks good, and then they upright the lowers, they go, yeah, it's not exactly as much as we thought it would be. And the lowers are still underexpanded. So even in our adult patients today, our protocol is to expand the lower first. And we do surgically facilitated orthodontic therapy on the lower arch and get as wide as we possibly can. And then we expand the upper to match that, because that we know that's the maximum we can get. So I think we've been expanding the wrong arch first. I think the lower arch needs to be pushed out where it should be, and then we can do the upper arch afterwards.
Wow.
Catch up.
That makes much sense. Thank you, she said. I cannot believe we only have 7 minutes left. We're not going to get to all of our questions, so we might have to have Dr. Rouse back if he agrees. But let's go to the next one. Before I keep going, I do want to remind everybody that tomorrow we have about 20 people on Facebook also watching us. Tomorrow at 6:30 p.m. Tomorrow is World Sleep Day, and we're going to have a special event. It's actually an podcast with Nicole Goldfarb. Her podcast with Airway Circle is called Airway Answers, Expanding Your Breadth of Knowledge. And she has invited Dr. Stanley Liu from Stanford University. He's coming back from Rome. I think tomorrow is going to go straight to our live. But he's going to be answering questions, and it's just going to be a very interactive, very fun. He wanted to do it live, so we're going to do it live, and it's only going to be available live. After that, it's going to go on the podcast in April, sometime in April. So you're welcome to come hang out with us tomorrow. The same thing tonight. It comes off the air right afterwards. If you're an Airway Circle member, you're welcome to go back and listen in. Next question.
Stanley's amazing, by the way. He's my hero. So he's so cool. Such a great guy.
I cannot wait. That's going to be such a good talk. So mark your calendars, guys, tomorrow at 6:30 p.m. The world of airway dentistry has grown very fast in the last several years. What are some of the screening tools that every dental office should have today?
So, it's a good question.
There are still some offices that don't have CBCTs where I am.
I don't have one.
So you don't think that's a must?
I have access to one, but I don't have one in my office.
Okay.
No, I don't want to spend $100,000 on something. I'm cheap. So I have some imaging center spend the money, and I use it. And I have an orthodontist that'll do it for me, and I have a periodontist that'll do it for me. So I'm just like the guy in Popeye. I'll pay you Tuesday for a hamburger today.
So which ones are the must-haves?
So cone beam is good, but cone beam can't diagnose.
Okay.
Right? So cone beam gives me anatomy.
Yeah.
Here's how we teach it at Spear, and the reason we teach it this way. There are lots of dentists and lots of your members that are going to be in offices that aren't fully bought into this. They don't, and they're not fully vested in it. And yet you see it, I see it, everyone sees it, it's there. So how do you how do you like answer what you know is the right thing to do if you can't get the people you're working with to invest in equipment to help you? And the answer is you just become aware. And so questions, all you have to do is ask questions. So the answer to that question is questions.
Amazing.
Just ask people questions, and then do an examination with an airway focus. Like the arch is narrow, the occlusion is whatever. But instead, it used to be that I wouldn't even notice that stuff. I might notice it if it was so bad that the smile was off, but I'd think about, this is back in the veneer day. You'd think, well, maybe I just make thick veneers and make, but now I go, wow, your arch is narrow. You can't breathe.
Wow.
And so you don't need any fancy equipment to do that. If you learn 4 things about the maxilla, you can figure people out. Do they, when they smile at you, show too much buccal cord or negative space? They're too narrow.
I'm going to have all 4. Go ahead.
Do they show too much vertical? Do they show too much gum?
Gummy smile.
Okay. So do they, when they bite down in the posterior teeth, are they end on or in cross bite?
I am.
Are they narrow in the back?
We're going to have all 4.
Okay.
What else?
Right. And the 4th is, do they have overjet, or are they near end to end? So if they're narrow and they're end to end, and when they smile at you, it looks narrow and they are gummy, you're like, if you have one or multiple of those, you're like, the maxilla is wrong. And if the maxilla is wrong, you can't breathe, more than likely. So when we put together a treatment plan, when people ask, I want the Hollywood smile, I think what they're really saying is, I want a healthy smile.
Yes.
I want my smile to be healthy, which is broad. Broad is healthy. Broad is beautiful. So the question was about things that I need. And honestly, you just need your own awareness. That's all you really need to do this stuff. You don't need, so just because the office isn't supportive of buying a bunch of stuff doesn't mean you can't do it. If I was to get one other thing past that, I would get a high resolution pulse oximeter that has, I would get a non and Bluetooth high resolution pulse oximeter, because I can get pulse ox data on fat old men, and I can get cardiopulmonary data on young fit females, which is monitoring sympathetic activity during the night. And then I would find somebody you can poach to get CBCTs off of, so you don't have to spend $100,000.
I love it.
Oh my goodness. You don't need that much. This is treatment planning. It's just a mental game. You don't need anything fancy. In fact, you don't need, I would never invest in a home sleep testing thing. I would never, those are worthless. So
I love it. So knowledge is the best screening tool. Anybody here
absolutely
has the power to get that. And that's why we're doing this with Airway Circle. We are trying to share as much knowledge as we can to increase the awareness in our professional community. So I would love to invite everybody who's watching today to invite one colleague that's not part of Airway Circle yet to come listen to us tomorrow with Dr. Stanley, for example. But invite one person that you think that could benefit from this. We also have a parent support group. Invite a mom that you know to join our parent support group where they can ask questions. But anyways, I do want to tell everybody that we have a brand new course launching April 1st. It's called Launch Your Inner Myo. That is not a myofunctional therapy course. We're not going to teach myo. It is after you have taken your first course. If you'd like to start your business, we're going to teach you step by step everything about how to start your business, from social media to marketing to your logo to your website, legal things. We have, a lawyer that's coming to talk to you guys. We're going to share the way that we do our evaluations, the way that we do our therapy sessions, and there's 4 of us. So you're going to see different people doing it differently. So we're not teaching you, this is how you should do. This is how all of us do it. And you guys can pick and choose from each one of our experiences to take it to your own practice. But literally by the end of this course, you will be ready. Your business will be hopefully starting to grow. And we are here to hold your hand throughout the whole process. So we're also sharing our favorite tools and exercises on that course. So join us. It's called Launch Your Inner Mayo. It is already, it's going to be from April 1st until August 7th. It's going to be an immersion course. That's what we're calling it. But Dr. Rouse, this has been such a wonderful hour. It went way faster than I thought it was going to. And for you
Thought
guys,
it was going to be horrible. Thought it would be awful and we'd have a hard time filling an hour.
My goodness. I mean, if you accept, would love to have you back. You were such.
Let me know. I'll come
We
back
could
anytime.
sit here I seriously could sit here forever listening to you like I did in Atlanta.
Well,
Oh, worth it.
So we're going to need probably about another maybe 3 hours.
Right. Well, he asked me, when I asked him, what would you like to speak to us about? And he said, well, why did you invite me? I said, I actually invited you because of your love for wine. I know that you have really good taste, so we could talk about wine too, but no, we were going to talk about Airway. But anyways, guys, thank you. Thanks for everybody for being here, asking questions and interacting with us. Dr. Rouse, how can people get in touch with you? Do you do online consultations? Do you have any courses coming up?
I teach out at Spear. So if speareducation.com, if you want to get in touch with or look at the courses and stuff, if you're a dentist, we're there are a ton of, actually, if you have access to, if you're not a dentist and you do have access through your dentist to Spear Education, I have created a bunch of patient education videos, animated videos. They're really short and they talk to the patients about issues like myofunctional therapy and why it would be important, and airway issues, things that where there's no other resource for it, and mouth taping, nasal breathing, tongue tie releases, all those are handled in these little short snippets that we've got available. So you might, if you have access through your dentist, you might take a look at those. I think they would be helpful in that practice and spreading the word about what y'all do. So
love it. Thank you so much.
Thanks for everyone.
Everybody have a wonderful night. Remember, this is coming off the air. So if you'd like to rewatch it, go to members.airwaycircle.com. We'll see y'all tomorrow at 6:30 p.m. Eastern Standard Time. Thank you, Dr. Rouse.
Bye-bye. Thanks.
Thank you, Dr. Rouse.